All right, I think we'll get started. My name is Nalini Saligram, and I'm the founder of Arogya World. We do diabetes prevention in India. And I have been representing Arogya World on the IPA, India Philanthropy Alliance, for the last 5 years as an interested and committed member. And we're organizing this health webinar today on behalf of the India Philanthropy Alliance. And to mark India Giving Day, which is the first India Giving Day is being held this week. I'm sure all of you know it's on March 2nd. And to tell you a little bit more about India Giving Day, we can have Alex Counts, who's leading the effort, to say a few words. But before that, the purpose of doing this webinar really is to bring to your attention as donors and as stakeholders, to ground you on some of the issues we care deeply about. The topic of this webinar is our vision for a healthier India. And, I really have been looking forward to this conversation. But Alex, over to you.
Well, thank you, Nalini. And, this idea of an India Giving Day began years ago when we started thinking, how can we, all of these organizations like Arogya World, like Project Echo, like Segal Foundation, and others who are represented here, they're doing such good work to combat such terrible problems in India and in a few cases in other countries. They need more resources, and they've shown how effective they can use the resources they have. And so we thought having a national day of giving to India, doing it in a joyous way, in a way that leads to more impact, would be something that could bring the whole nation together. All those of us who care about India, either because we're from India or like me, that India's kind of entered our lives and become an integral part of who we are, even though that's not where our family is come from. So we are excited in this countdown to India Giving Day that is coming up this Thursday. We hope you all will visit our website, will be part of it in any way that is meaningful to you and to the organizations and people around you. And public health is a key aspect of the India that we're all trying to create. And Sanjeev and Nalini and others who will be speaking tonight can really give you a window on that reality, how we're going to get to a healthy India, an India that has dodged the bullet of diabetes and diseases that are lifestyle based, and we're just so pleased to be able to be part of this. So join India Giving Day, but enjoy this time together.
So Alex, we also want to take this opportunity to thank our sponsors of India Giving Day, especially Rural India Supporting Trust and MasterCard and Bank of America, among others. Yes, thank you. There was a slide, I knew. So without sponsorships and without support, big efforts like this can't take off. So we really are grateful to all our sponsors for supporting this India Giving Day. Over to the main point of this webinar. I've been looking forward to this conversation with Dr. Sanjeev Arora, who founded Project Echo and has built it to a phenomenon in public health today. He's a visionary healthcare leader, somebody for whom I have deep regard. So I really am looking forward to this conversation. I wanted to just ask you, Dr. Sanjeev, to set the stage with a few remarks overall on the sort of healthcare scene in India today, and how we want to, work towards getting India closer to that Sustainable Development Goal number 3.
Thank you, Nalini. First of all, for many years, getting to know you has been an honor, and been truly inspired by your work and the work of Alex Counts, who's really put the Indian Philanthropy Alliance together and bringing us together. And I think that's the key secret. There is so much talent in the US and other parts of the world of people from India and bringing them together, talent and resources can be transformative for India. But the fundamental issue that I see in India for healthcare is that we have sort of two systems. We have a system for the rich. In the cities, we have these amazing doctors. We have these amazing hospitals that compare with hospitals in the United States. Many of them have better outcomes. People from all over the world are traveling there for care. And it's a robust export industry. But at the same time, we have the villages and small towns where there is no specialist, there are no expertise. For a poor person in India to get the right knowledge at the right place at the right time is an extraordinary challenge. They have to travel long distances to cities. They often don't have enough money to see the specialists. And so now we've divided this country into the haves and have-nots of healthcare. And it doesn't have to be that way. And that is my dream. And I know it is yours, Nalini, that we can devote our energy and effort to create equity so that nobody has to die because the right knowledge doesn't exist at the right place at the right time. And we want to democratize the experts of the people who live in our city, about world-class experts. But we need to take it to the last mile of healthcare.
Right. And you know, India is a vast country, 1.4 billion people, and the issues that India faces in healthcare are so vast. The country has fought maternal and child mortality. I was so encouraged to read Bill Gates's latest letter, which says, hey, 96% drop in measles in India, it is worth celebrating. It is amazing. I used to work at Merck Vaccines, and for me, you know, it's to see diarrheal disease come down, and these childhood and under 5 childhood mortality come down, even maternal mortality come down, is really wonderful. I'm very encouraged by that. India, when we put our minds to it, really can solve seemingly intractable challenges. And these non-communicable diseases are one of those intractable challenges. The problem is so big, and India is so beset with these diseases. Just to give a couple stats, non-diabetes, for example, people in cities, 3 out of 4 people are either diabetic or pre-diabetic. And how are you going to solve a problem that is so widespread? And Indians get the disease at age 30, some 10, 20 years earlier than people in America. So the problem is genuinely huge. And now even 10-year-olds are running around. A third of the 10-year-olds in India have high blood pressure. Imagine their health when they become 20. So this is a real big problem. And, you know, so we genuinely feel that while infectious diseases have at least some glimmer of hope, COVID did a lot to set the country back. And I know you have made great strides, and Project Echo has made great strides to combat some of the setbacks from COVID. So I wanted to hear from you, Dr. Sanjeev. What is, you know, what gives you hope with regard to the frontline workers in India and everything that you've been able to do with Project Echo with them?
Yeah, I think that what we've developed is something called the Echo model, which is based on the idea of democratizing the implementation of best practices all over the world. And we currently work we have about 4.1 million learners in 193 countries. But the basic idea of Echo started with just a single patient, where I saw this 43-year-old woman in my office, and she had 2 children, a 14-year-old boy and a 9-year-old girl. And I asked her, how can I help you? And she said, you know, I have hepatitis C and I want treatment. So I said, how long have you had it? I've had it for 8 years. So I said, why did you not come earlier? And she said, I live 200 miles away. And your nurse said, I would make 12 trips each way to come and see you. And I couldn't take so much time off work. So I decided not to get treatment. So I said, why did you come today? She said, I'm having pain in my abdomen. And I did an ultrasound. She had a cancer of her liver. And she passed 6 months later, leaving these two children. And I was saying, why did she die in the United States where I have this expertise and I have the treatments? And the answer was she died because the right knowledge didn't exist at the right place at the right time. And so I developed the ECHO model based on the use of technology to leverage expertise, one-to-many video conferencing, sharing best practices. But the heart of ECHO is something which we call case-based learning, where we'll have all these doctors from New Mexico. They would join all at once on a Wednesday afternoon, and we would give them, we would discuss cases, just discuss cases one after the other. And what we found was this was the way they had learned it during their residency and fellowship, and they became great experts in a year. Over the next few years, we were able to treat more than 10,000 patients and get tremendous results. But as we found this, we found that we had developed a mechanism to do what we call force multiplication. That is to take the expertise which is centrally located and then magnify it so it reaches everywhere. And once we did it for hepatitis C, the next thing we did it for diabetes, and then cancer, and then we did it for HIV, and then we did it for many non-communicable diseases, blood pressure, etc., heart attacks, prevention of cardiac disease, cancer prevention. And now we actually have 70 different types of ECHO projects. We have about 3,000 networks working in the world. As I mentioned, with 4.1 million learners. And we have impacted the lives of close to 150 million people globally. But what happened when COVID-19 came along in India, there was this very unique problem that there was this new disease from which people were dying, and doctors and nurses did not have the capacity to treat them because they didn't know what to do. In fact, there was a lot of noise in the system with hydroxychloroquine and all kinds of things which were not very effective. So what we did is we partnered with the Indian government, central government, and all the states, and brought global experts who had the latest research knowledge and got this information out along with management of cases to close to 700,000 healthcare professionals, doctors, nurses, community health workers. And as you pointed out, that one of the biggest problems in India is non-communicable diseases. Diabetes is a highly untreated, highly unprevented problem. And so we just like you focus on that. A lot of our focus is on treatment, but we also work with ASHA workers, for example, and train them on many areas such as cervical cancer prevention or early diagnosis of breast cancer or diet and nutrition and things of that nature, obesity. So I think, but the idea is, can an expert multiply their impact on their community 100-fold by, instead of saying, I will only help the patients who come to see me, saying, I will mentor other people to be as good as me through this, what we call ECHO model. And so it's been very gratifying to work in India, Nalini, because I grew up there, went to medical school there.
Right. So do you feel COVID set us back in India, or have people now used the systems that were put in place because of COVID? I mean, the vaccination story is fantastic in India, but what is your perspective on COVID and its impact?
So Nalini, in every country in the world, including the United States, COVID set back management of chronic disease substantially. just in a simple field like cancer screening, prevention, and diagnosis, the National Cancer Institute has estimated globally millions of excess lives were lost because cancers couldn't get diagnosed, patients could be seen, cervical cancer screening was abandoned, breast cancer screening was abandoned, colorectal cancer screening, lung cancer. So essentially, that's one disease. Diseases like diabetes didn't get treated, complications occurred, people who had preventable heart disease got heart attacks. All of this occurred. I think that, as you pointed out so nicely, India has made a lot of progress over the years, and it's been so gratifying to see the progress, specifically in the last 15 years or so. But much more work needs to be done. The progress has been done we've made huge progress in areas such as maternal health, vaccination, because these are, I do agree, the low-hanging fruit. But still, too many women die of cervical cancer, which is a completely preventable disease in India, by the vaccine and with the pap smear screening. But we have one of the highest deaths in the world from cervical cancer. Similarly, breast cancer outcomes in India are some of the worst in the world because breast cancer is diagnosed so late. When just trained ASHA workers can help women diagnose this, treat early. So we have made a lot of economic progress and a lot of progress in health. And I'm really excited about the national health insurance schemes but now we've developed experts all over the cities, but we need to, just as you are doing, Nalini, get the knowledge to the patients where they live so they can care for themselves, they can get access to these life-saving interventions, which is not happening enough.
Right, right. So we can pivot to some questions, or
I have a question for you.
Okay.
So, you've made these great strides in non-communicable disease prevention in India, and as you really pointed out into the introductions that you gave, India is rapidly moving from a stage where a lot of the deaths were from infectious disease to a place where NCDs will be the major cause of death, far outpacing infectious diseases. And this is the natural history of any country developing. So I'd like to hear from you, what is about your approach and what has it made you so successful?
I don't know if we can call what we have achieved success, but it just keeps spurring us on. All of my colleagues who are on the call as well, we're really energized by the difference we see we are making. So that keeps us going. The reason I founded this organization is to work with like-minded people and organizations and make a meaningful contribution to global health. And that keeps us going even today, more than 10 years later. But you see, just look at the advances in technology in India. It's really exciting to go to these health tech conferences and see the number of startups and the amount of investment. And it's genuinely exciting to watch that. But I stood up at one of these meetings once and said, hey, do you know you guys are so excited about the future? But all your 27 and 30-year-olds are going to get diabetes and heart disease very soon. So what you really must worry about is your non-communicable disease burden and what can you do for that for your employees. So we work in a model that sort of spares the precious healthcare resources. So people like you, Dr. Sanjeev, can save lives and save your resources and your knowledge to actually give attention to people who need medical attention, urgent medical attention. But people like us, can step in and provide what we call a lifestyle change prescription, because that whole lifestyle change thing gets short shrift in a doctor's office. They don't have the time, so they don't cover it. But we step in and we can cover it, and we cover it in the community setting outside the doctor's office. And we do it in schools and in workplaces, and we also use mobile technology and even social media to educate. And so we have multiple programs. We've reached some 9.3 million people so far. But by far, for me, the most exciting is what we started on last year, to make whole cities collaborate and persuade different groups in cities to take up pledges voluntarily and improve the health of people around them. So we have made Bangalore India's first Arogya city, and 21 pledge makers, companies big and small, startups, academia, nonprofits, all stepped up and have taken pledges. They really are heroes, these pledge makers. But it's very exciting to see multi-stakeholder collaboration on the ground is possible. It's not just a concept, it is really doable. So we are very excited by the sort of the next stage in the evolution of Arogya World, because we feel we can scale. We have shown proof of concept, and now our job is to scale.
No, thank you, Nalini. As you pointed out, the biggest cause of deaths of Indian men is still heart attacks. And it is often due to untreated diabetes, untreated hypertension, untreated cholesterol, and so much of this can be managed with lifestyle and appropriate screening, etc. So thank you for your work, and yeah, we'd love to go to the audience and
yeah. So we have two more people, two more groups who are part of the India Giving Day community who are here. And I wanted to get their perspectives before we go to the audience. Is Sumani Dash from American Friends of HelpAge India here?
I am.
Okay, great. So Mani, over to you. If you can take a few minutes and just provide your perspectives on healthcare in India and what you guys are doing.
Sure. Thank you. Thank you, Nalini. And thank you, Dr. Arora. It's such a pleasure to share a stage with both of you, such visionaries, I think, both in your own ways. And I've really long been an admirer of both of your organizations and the tremendous work that you're all doing. So thank you for your leadership in the public health space. HelpAge India is a 44-year-old nonprofit that has been really working at scale in 26 states of India, specifically on the cause of disadvantaged elders. And currently, there's 1 in 4 elders in India that do not have access to healthcare. And we have a variety of interventions that have been designed. We really take a 360-degree view of well-being, whether it's economic and financial, but health is certainly a very big part of it, just because of the process of aging and all of the sort of issues that brings in terms of the healthcare interventions that are required. And a lot of people just don't have access or cannot afford it. So very much in terms of, Dr. Arora's thought on the democratizing the healthcare system and to really make it accessible and available. One of our sort of flagship initiatives is a mobile health units initiative, which we have 167 mobile health units currently running in 24 states of India, and they provide free primary care treatments to elders and their communities. These are in urban slums, tier 2 cities, very remote rural locations as well. So they provide, the first sort of level of screening, and also regular medication, etc., is being made available. So each of these units comes with a doctor, a social worker, a pharmacist, and a community organizer, where they're also able to connect elderly with government services, etc., that they might not have had access to. And they can also provide referrals for those, more complicated cases and so forth. But I do, again, to Dr. Arora's point, those are not always easily available in those rural setups. And so people may have to travel, and HelpAge does hand-holding as much as possible to get the elderly that need that kind of help and support. We also have a big program in vision restoration. We've done 1.2 million cataract surgery facilitations over the years. We've had a partnership with USAID on vaccine facilitation. So about 1.8 million people were vaccinated under a HelpAge India banner in partnership with USAID and other partners. So lots of work around public health, on physiotherapy and other such sort of, just aging related issues that require healthcare interventions. HelpAge is just doing its best to make sure that elders that do not have the resources or means can get access. So that's a huge part of our work. So I appreciate the opportunity to talk about it. Thank you.
Thank you. Thank you. And it might interest you, Sumani, to know that in Bangalore, in that Arogya city, two groups were elder care.
Wonderful.
So one called Senior G, a small startup, and another one called Vaya Vikas, which is also starting. So very interesting that you may come across them at some stage.
Yeah, no, I mean, I think more people hopefully are paying attention to the demographic trends in India and the problem we're going to have with aging populations. And we're looking at 320 million elders by 2050 in India. I'm not sure we're really prepared to, how we're going to provide the services and all of the things that would be required. So I'm glad folks are participating from that segment. Thank you, Nalini.
Great. And we have one more person who's going to say a few words, and that is Neha Madiwala from Arman. Arman is another success story we've all been watching. It's really exciting to see. Nonprofits make waves on the global stage from India. So it's really exciting. Neha, over to you. Also a member of the India Giving Day community.
Hello, good morning or good evening to friends in the US. So I'm sure that most people are aware of Arman. Arman is working in the space of maternal and child health, which again remains a big priority for India because although we have seen a kind of at least a decline in maternal deaths, the status of health of the Indian mothers and newborns continues to be very worrying. Problems like anemia or low birth weight, are huge in India, and given the population size of India, we contribute to the largest number of we still continue to contribute the largest number of deaths, maternal deaths to the world. The problems of, maternal health, if you know what has happened in India, is that there has been a lot of focus on providing medical services or emergency medical care, institutionalizing deliveries, ensuring that women deliver at hospitals, all of which have, given dividends, in terms of reducing certain, problems which were resulting from, sepsis or resulting from, postpartum hemorrhage, which were the major causes of death in India, maternal deaths. But there is a lot of, of the problems which are basically essentially related to poverty. And those are, they manifest themselves in things like anemia, like 60% of Indian mothers are anemic. A large proportion of them are severely anemic, so these problems are related to, the absence of healthcare, also the absence of information, and, and an ability to care for oneself. So Arman manages two of the largest M-Health programs in the world, Kilkari and M-Mitra. Kilkari is a national level program, and it is, it is owned by the Ministry of Health and Family Welfare. It's a government program, and it delivers information on maternal and child health targeted to women, pregnant women, and mothers of infants across a large number of states in India. What we have learned from M-Mitra, which is our indigenous program, which has a base of 2.5 lakhs or 0.25 million women. Every year we enroll 0.25 million women in that program. We have been endeavoring to translate into Kilkari, which is a larger government program. What we have found is that technology definitely is the way ahead if you want to have at scale programs, because the number of women that we are able to reach is enormous. It is stupendous, and we have found that M-Health programs have the capacity to deliver information pretty efficiently. Women are better informed, and we are able to we are able to record, or we are able to see changes in health behavior, which are following the which sort of are associated with this exposure to these programs. Of course, there are a lot of intermediate factors, and one of the interesting aspects of M-Health is that a lot of the times the M-Health program is mediated by men, because women don't have access to phones. Whereas this has always been seen as a burden or an obstacle in generally in the field. It also can be seen as a kind of an advantage, because one of the problems in maternal health in India is that it is always focused on women, which doesn't allow us to address many questions of gender, which are crucial and which are actually at the root of many of the maternal health problems that we see. So, for example, say the amount of food or the kind of food that pregnant women have access to is determined by the gender norms, determined by who makes purchases of food, who decides what should be bought, how much women can spend on themselves. So these are the things which are really at the root of social issues, or such structural issues are really at the root of many of the public health problems in India, especially like in the domain of maternal health, which we find that there is a way of actually addressing these because of the technology that we are using, which does enable us to access men. And at least in the work that we have been doing, we find that one of the things that M-Mitra program has been able to do is provoke conversations between husbands and wives on health, on the woman's pregnancy, on her health, on her sense of well-being, which is very priceless. I mean, even though we may feel that this kind of thing may pale in comparison to the major problems of delivery of healthcare, but at the micro level, these small conversations really and in happening in thousands and hundreds of thousands of households, has a potential to transform the way that women experience pregnancy. So we feel that the technology is just begun. It's still new. There is a lot of the road is sort of really still untraveled. And we feel that there is a lot of potential in putting this kind of technology to use, and actually ensuring that it becomes part of the health system rather than as a kind of a standalone intervention, so that it begins to complement healthcare delivery on the ground. So this is the hope that we have.
Right. No, that's really, it's really great. I had the pleasure of meeting Dr. Aparna at Clinton Global Initiative meeting a few months ago. But 2 points I wanted to say. One, personal. I just became a grandmother. My daughter, tomorrow is my granddaughter's first month birthday. So this was front and center for me, all this maternal issues at childbirth. So I wanted to say that. And the other thing is that two of our programs may actually, Arogya World programs may be of interest to you. One is called My Thali. We have a picture of a thali that shows a woman what she should eat and in what quantities at every at every meal. So so we push both balanced meals as well as portion size. So this healthy eating is something that I think is fundamental. Of course, it's the number one cause of death, unhealthy eating. So if we all work towards improving healthy eating, it'll be great. But the other point is the anemia. So we have adapted this Maithali for rural adolescent girls. And we are tackling anemia right there with comic book type conversations, aspirational conversations. And we have a program with MS University Baroda to do an effectiveness trial in that. It's ongoing right now. So I think it's really helpful to know what each one of us is doing, because there are many synergies and possibilities for collaboration. But I wanted to take the, sort of 5-10 minutes to see if we have questions. I can see some chat. Okay, is there any? Okay, that's fine. Jay had to drop off, but if there are any questions for any of the people, otherwise I will ask.
I think there is
I have
go ahead.
Go ahead. No, Dr. Sanjeev, go ahead.
Okay, I think there's a doctor on the network right now. I just learned that he's here. Who's talking about a slightly different problem, but there's another huge issue in India, is that our suicide rate in young men is very, very high. And this individual, Dr. Prabhat Chand from National Institute of Mental Health and Neurosciences, is on and has developed some really amazing programs to bring better mental health to people. So Prabhat, would you have a moment to talk about that?
Yeah.
Yeah.
I think thanks Sanjeev and thanks Nalini. I mean, actually just an entry. I just saw the link in the social media, and I thought of join. To look.
Oh, wonderful. Thank you.
Thanks, Alex, to allow me to join. Yeah. So I think I'm a psychiatrist at National Institute of Mental Health and Neurosciences, Bangalore. So I'm basically academician and clinician. So I started ECHO in 2013 when I was realizing that Karnataka at the time, addiction was a big problem.
Can't hear you so well. Can you switch off your video maybe?
Oh, sorry.
Can't hear you, Dr.
Can't
Prabhat.
hear you, Prabhat. I think you have to shut off your video.
Yeah.
So I went to ECHO in Albuquerque,
Can't
spent
hear
some
you.
time, and 2014 and stuff. Okay. Yes. Poor. Is it okay now?
No, can't hear you. Yeah, we lost him.
Yeah, lost him. Okay.
Is it better
But
now?
Yeah.
yes, we can hear you now.
Yeah. So actually, I'm in Gorakhpur in Uttar Pradesh, where the systems are not very good. So I'm connected to my mobile hotspot now. Okay. So we started doing for I probably just get back in 2014. I spent some time in Albuquerque in US to democratize knowledge, and I came back here. So we did first study in Bihar, and Bihar is one of the rural states in India where you don't have psychiatrists available there. In that study, we looked at if you can train the primary physicians, will they able to manage alcohol addiction as good as me at Niman's as addiction psychiatrist? And we realized 85% of the patients they could manage in the in the primary care or community healthcare system. Only 15% they would refer to the specialist. I'm talking about a place like Bihar, which is not very well connected. So then you published it. Then you expanded to Chhattisgarh, which is further a very remote part. It's very poorly connected. And they don't have any mental health program at all, because there are no psychiatrists to run the program. So there, when we started the program, connecting all the hub and spoke model, and Professor Sanjeev must have spoken about that. 8,000 patients were seen a year, but over the 2 years, 70,000. So physicians could screen at least for anxiety, depression, alcohol. I mean, obviously, severe psychotic illnesses are difficult to pick up. 70,000 people, and the health system make free medicines available on those districts, facilities. So this is how it grown, and it has expanded over the time. And 2018, government of India took it over, and it became a digital academy, looking the work they were doing. So the sustenance become much easier, and obviously, it expand to much more bigger areas. I'll stop here because of lack of time.
No, that's
Thank you.
great. So of interest to you, Dr. Prabhat, we know Dr. Pratibha Murthy very well in Bangalore, and then Sanjeev, it will be of interest to you. So it is really a very small world. And it may interest you to know that we, Arogya World, we have a mental health component of our Healthy Workplace program. So we are the first to have added mental health requirements as we assess companies for whether they are truly a healthy workplace or not. So for us, they have to do things right for physical health. They also have to do things right for the mental health of their employees, and it's equal. We give it equal marks when we assess them. So we are very excited that companies, about 20-30 companies have qualified for both physical health and mental health. And we are also partnering with other organizations to bring mental health training as well as mental health service. And we're scoring for uptake of mental health services in these healthy workplaces. So it's really, quite exciting to see that happening. Any questions from anyone? For any of the people?
I have one.
Yes, please.
I was wondering, I'm part of Children's Hope India, which has 20 different projects in India, and they're mainly aimed at children. But after listening to you all, I think that, we have to kind of go to the extended family, and the community and try to make a difference over there. So I was wondering if one could collaborate in a way where we get information from you all and we try to reach out to the communities, because these are slum communities or they are village communities where, there's a father, a mother, and then there's the extended family. So that we could reach them all basically, because I got kind of really concerned about diabetes figures, like you mentioned, and sort of, if one could get started or even just create awareness, that would be great.
So real music, Lavina, to our ears. We would love to collaborate with you. We have an adolescent health program that has reached 750,000 kids, and we teach these 11, 12-year-olds about the basics of eating right, basics about healthy, physical activity. So at the end of our programs, we know, for example, that the girls are not sitting and talking to their friends. They actually go out and play. For us, that's real success. And they eat more fruits and vegetables, not just the girls, the boys as well. So it's really quite exciting. From our side, we would love to partner with you and with anybody else on this call or in our communities, because we really do believe in the power of collaboration. Cannot solve this crisis on our own. Cannot.
That's true. So we just have to kind of come up with a way where we can do it, in a smart way, because there's already so much pressure on these communities, even on our teachers. So we have to do it in a way
Yes.
we can kind of do it very effortlessly and bring it in somehow.
Yeah, absolutely. We have digitized it, but others will have, I think, in your community. In fact, our latest sort of concept is that a surround sound system is needed to move the family to a healthy family. So the child has to come home from school and say, I learned this in school. And the father has to say, I got this on as a text message on my, and the frontline worker has to come and say, hey, come to this community event where I'm going to talk about, fruits and vegetables and their importance in today's diet. And so these kinds of things really do contribute to the family. And that's our latest concept is, hey, multiple public health interventions are needed to get the family, entire community, entire village to become healthy. So
that's really great. So maybe I can be in touch with
absolutely
you and get some ideas.
I will put my email address in, just like Sanjeev did. But if anyone else wants to comment.
Okay, great. Yeah.
Yeah, and
Thank you.
Davina, we also will be happy to support you in any way if you want to write to us and tell us how we can be helpful.
I will absolutely do that because the community has everybody, even for this helping India age, the age
Help age. Mhm.
help age, because there are also older people in the community. So if we could really reach out to all of them through our children, that would be great. So I'll be connected with all four of you.
Absolutely. Please do.
You know, and Nalini, I wanted to mention for all of you working on social impact projects that we have a technology platform which we could bring, including the Zoom licenses, etc., at no cost to you,
Wow.
to allow you to really have impact at scale. And I think to the extent that you reach out to me and you're interested in expanding your programs and technology platforms could be helpful to you, we would be happy to support you. We are always looking for organizations to support who are interested in this idea of social impact. So, and I
That's
put my
great.
email, please reach out. Yeah.
Yeah, thank you.
Dr. Arora, would love to talk to you in case that platform also applies to telehealth. I'm not sure if that's okay, because from our mobile health units, I've been trying to rack my brains on how we could possibly scale that further. I think there's a lot of capacity that we could look at. And separately for Dr. Prabhat, I just wanted to mention that HelpAge now has a collaboration with Nimhans to train 10,000 frontline health workers on geriatric mental health, because that's a huge issue we've seen come out of COVID especially. So that was just announced in October. So just wanted to mention some good collaboration already underway.
Great.
Great. Great.
Nalini?
Yes.
So, well, first of all, thanks to the panel, and I've just been, I planned to just observe this, but this has drawn me in, as I'm sure it has for everyone here and all those who will view this later. But basically, it sounds like what we're talking about here fundamentally is behavior change communication.
Right.
And it's applicable to agricultural extension, to preventative health, to curative health, to so many things that we care about across IPA. And one of the things I've learned at several points in my career, it's one thing to deliver useful information to people. It's another thing to actually educate them so they retain that information so they can repeat it back to you the next day. But the holy grail, as we know, is actually behavior change, which doesn't necessarily happen if you deliver information or even if information is absorbed by someone. And so I'd be interested in the panel or anyone else who's with us this evening. I'm just curious, what are a couple of the breakthrough ideas in behavior change communication and really changing behaviors through the kinds of things we've been talking about tonight in the last 5 years, like the insight that we didn't have 5 years ago that we have now, and what are the big bets? What are the things that we're experimenting now that could actually be the breakthrough in behavior change in the next 5 years that we're hopeful about, but maybe is not yet proven?
So let me go first because I have just two quick thoughts. One is behavior change. You can persuade someone to change behavior if the bearer of the news is someone like me. So, if I listen most to an influencer who's like me. So finding the right influencer in every community is very, very important. So that's one. And the other is the use of artificial intelligence. I think it's going to change how we communicate and what we communicate and personalize and customize. And, it's not just personalized medicine, it's personalized behavior change communications that is going to happen.
I think Alex.
So we had.
Go ahead. Go ahead. Please go ahead.
So at Arman, where we have a range of different health programs, one of the things that we realized is that the key to bridging the sort of the gap between knowledge and behavior change, knowing something and actually acting on it, is interpersonal interactions. So because something has to change in the context of the woman. Say, for example, because we work with women, so whether it's relationships at home, relationships between her and the healthcare provider, and the way the information health information works is by giving her a vocabulary, by being able for her to be able to express what she is going through and to be able to discuss it with others. And this can be quite powerful, because it's working at two levels. One, it's working on her own mind, allowing her to understand her own body and her own her own condition better, and then also it is allowing her to establish, sort of communicate with others, and change some relationships. The other thing that we realized as a program is that especially for women who are more vulnerable, two-way communication is absolutely essential. Just delivering information to them and hoping that things will happen doesn't work. So we started a live telephonic counseling service for women whose babies are moderately underweight, so they are malnourished. And we realized that it's a program which is a 4-month long program, and we make weekly calls. A nutrition counselor makes a weekly call to these women. And typically, women with malnourished babies are the ones who are the most marginalized. They're the less educated, low income, don't have access to other sources of information. And what we found really helps is problem solving. So because these women don't have the ability to use technology effectively, because of their lack of education, a live call is completely technology, it's free, it's barrier free, because they don't need to do anything except to talk with the counselors. And we realized that the two-way communication which we were able to do on the live call, it's typically a 6 or a 7 minute call, allows her to do problem solving. And problem solving is key actually to behavior change, because she has to overcome what she she perceives as the barriers which are not allowing her to put what she knows into practice. So I think that technology will have to move to that level, that how do we actually scale up two-way communication, and two-way communication which is barrier free, because a lot of the two-way communication that we are designing right now requires more and more knowledge of technology, which is excluding the poorest and the most disadvantaged users. So I think this is a challenge for us. It's a design challenge actually. And I agree with Nalini, is that personalizing information, information and whatever we communicate, it has to resonate with their reality. It has to
Yeah.
make sense to them. So and digital media
Okay,
that
we
way
have,
is
sorry, Neha, we have just a few minutes left to end this call to keep everyone on time. And Sanjeev, Dr.
sure.
Sanjeev wanted to say something. Sorry, huh?
Yeah,
Okay.
it just so happens we have a world expert, a different psychiatrist on the call to answer Alex's question, because it is the most critical question for humankind, right? How do we change behavior? Prabhat, you want to comment on this? You've done this all your life, ever since medical school. So go ahead.
I mean, I know it's obviously, Alex, you ask a very difficult question, to all of us. I mean, I do it day in, day out, because as Sanjeev mentioned, I work in addiction psychiatrist. It's my job. I do it. But what I realized over the time, it's probably it's some sort of mentoring and some sort of modeling. So you have to find key mentors in the community. I mean, this is how happened last 10 years at Oniman Seko I do. I probably look at the mentors in the program, and they and give the power to them to change. So creating, I think Nalin did mention about that, creating the key people as a mentors, young mentors, or whatever they are, and different areas not specific, and that's they do it, and they look at you, and that conflict has to resolve. That I tell you do, or you tell I do. I mean, that's very critical. I'm about to decide it, but still, it's a long way to go. But I think that's very critical to mentor. Example, I'll tell I'm here outside, and one of the spokes on physicians yesterday gave a call to me. I mean, program is over, but he got called to me to tell about his son's problem, who is in US. So I just took the call. I have every right not to take the call. But those are the small issues. But I think this might. Sorry. Thanks.
No,
I
that's great.
stopped
That's
here.
great. Hey, I know we're at time, but I have a board colleague on the call today, and Deepa Prahlad, one of the foremost thinkers of her generation, Professor C.K., late Professor C.K. Prahlad's daughter. So Deepa, if you're still here, please, would you want to comment on behavior change and what is required?
Well, I think this has been such an amazing discussion. Happy to see all of you, and thank you for having me. But I think that there's just a few things from the design perspective. I think the issue is absolutely, India's particularly challenged with this dichotomy between rich and poor. And the one thing they have in common is both are overwhelmed with information and data. And I think that the design can really help cut through all of that noise. So I think with programs like My Thali, where even very intelligent people can't necessarily decipher, what do those guidelines mean? Giving that pictorial reference is something that's valuable at both ends of the spectrum. So I think many ways to communicate, and this component, I agree, many of the other speakers have referenced, it's not only information that enables change, it's information plus support. And we've seen this, even in how with draft animals, one can pull 8,000 pounds, two together pull 22,000 pounds, but with a little training, they pull 30,000 pounds. So just even having one point of support is absolutely critical. And I think what we learned as an organization that powered us early on is doing a study of 10,000 women, and the cost of not doing it is so overwhelming. We saw even back then that, women were saying that 25% of their household income is completely taken away if even one member of the house has an NCD. There is no amount of economic growth that can compensate for that many women dropping out of the workforce, for that kind of damage to the family, and for India at a much earlier age. But I think the more fun thing that I think all of us, when we're dealing with serious problems, I think Alex had that at the beginning, making this joyful, right? I mean, people do hard things when they're fun and when they have support. And I think that's something that shouldn't be forgotten, even though the issues we're trying to address are very serious. So I think we've only looked at games in our schools program, but I think that that mindset is so powerful elsewhere. You can get people to lose weight by giving them a lot of statistics or by giving them 2 tickets to Hawaii. And they might slim down in both cases, but one would certainly be more fun.
Thank you, Deepa. Sanjeev, any final comments? We have to end, we're past time, but do you have any words of wisdom for us?
I want to express my gratitude to you, Alex, and everybody who agreed to join. And thank you for this opportunity. And I think the key message from my perspective is India is a big country. For us to make a difference, we have to figure out a way to collaborate with each other to really do what Ms. Prahlad just said. I love that analogy of when we support each other. That is the highlight of my work in ECHO. We found exactly the same thing. When you build communities of practice, you achieve, it's synergistic. And I think that similarly, social entrepreneurs collaborating with each other can also be similarly synergistic. And so thank you again for hosting this.
Yeah, no, this is great. And I too want to end on this sort of hope and note of collaboration. It is, Alex knows very well, it is my pet project to bring collaboration on the ground to the work of the IPA in the future evolution of the IPA. And there are so many groups that are now coalitions that have spawned. I'm a member of Catalyst 2030 that is really bulldozing toward the world towards getting close to that SDGs 2030 goals. So really, collaboration is the only way. We have all invested in our own infrastructure, in our own content, in our own machine, and in our own technology. But if only we share all that, the world can get closer. to the SDGs. So look forward to lots more. I was really energized by this conversation. Thank you very, very much for your attention and time.